I am Dr. Allan Klein from the Cleveland Clinic, and it's my great pleasure to discuss the ROTEA study. The role of T compared to CT in evaluation of pulmonary vein ablation for atrial fibrillation. Now I'd like to talk about the background of the study. As you know, that radiofrequency ablation has been used to treat patients with atrial fibrillation. Now concomitant with that, we have CT and T, which both have been used to assess the pulmonary veins before and after ablation. CT has the advantage of superior spatial resolution, but is limited by the radiation and contrast exposure. On the other hand, T is a gold standard for ruling out thrombus in the left atrial appendage, and post-ablation can assess pulmonary vein stenosis as well. There's never been a head-to-head challenge of CT versus T, so therefore the objective of this study was to compare T versus CT in patients undergoing ablation for atrial fibrillation. In terms of the design and methodology of the study, first this was a single observational study in patients undergoing ablation at the Cleveland Clinic. Patients had to have a CT and T within 24 hours of the ablation and return for a 3-month follow-up. We did specific imaging of the left atrial appendage and pulmonary veins, trying to measure dimensions, and similarly by CT we assessed en-face views of the pulmonary veins. For stenosis, we calculated a percent area reduction. The first illustration shows how we measure the pulmonary veins both by CT and T. And as you can see, the veins by CT are elliptical in nature with a major axis and a minor axis. Similarly by T, you can see the ostium of the pulmonary vein measured at 110 degrees. What were the results of the study? We were able to enroll 43 patients in this study, and in terms of anatomy of the pulmonary veins, clearly CT was better than T for looking at common left pulmonary vein atrium, and was similar to T for assessing the right middle pulmonary veins. With T, we were able to obtain 98% of veins, which is an important finding, with experienced operators. I'd like to illustrate a movie showing the separate ostium of the right middle vein, both by CT and T. How about osteo dimensions? Clearly, with CT pulmonary vein ostium were elliptical in nature, and unfortunately T underestimated the sizes of these osteo measurements. Post-ablation, there were some changes of the pulmonary vein. The pulmonary vein osteo dimensions decreased in size, suggesting some type of thickness after the ablation, both on CT and T. There was a good correlation with the two techniques. By cardiac CT, we were able to obtain 2 veins that had a mild stenosis. Similarly, T was able to find these two veins that had stenosis using a little different technique, a combination of anatomic narrowing, spectral broadening, aliasing, and a high flow velocity more than 110 centimeters per second. The next illustration shows pulmonary vein stenosis of the left superior pulmonary vein, both by CT and by T. And as you can see, by CT there was a marked area reduction. And by T you can see alias flow velocity and a high velocity more than 120 centimeters per second. Post-ablation, we were able to identify severe spontaneous echo contrast, low appendage flow velocities in 10% of patients who actually were in sinus rhythm. This suggests a very high-risk state, and perhaps we should continue Coumadin in these patients. In summary, the ROTEA study was the first prospective head-to-head challenge comparing T versus CT for pulmonary vein anatomy pre- and post-ablation. We also demonstrated with experienced operators we can actually identify 98% of the pulmonary veins and assess functional stenosis. And we also did provide additional information on the left atrial appendage, left atrial function in patients that are high risk for thromboembolism. I'd like to thank the American Society of Echo for sponsoring this research. Thank you for your attention.